we're very pleased and honored to have such a prestigious panel with us today. And it's my job to that's your job, to introduce them very quickly. And on the end, we have Alisha Moreland Kapuya, is the co-founder of the Kapuya Foundation and Chief Medical Director for Volunteers of America. She is Executive Director of the Avel Gordley Center for Healing and Assistant Professor of Public Psychiatry at OHSU. She's on the board of Oregon Health Policy Board, Healthcare Workforce Committee, and previously served on Portland's Community Oversight Advisory Board and the Governor's Council on Alcohol and Drug Abuse Programs. More importantly than all that, she is a City Club member. Next, we have Dr. Berwick. Donald Berwick is President Emeritus, Institute for Healthcare Improvement, and former administrator of the Centers for Medicare and Medicaid Services. In 1991, he founded the Institute for Healthcare Improvement, which continues to be a leading organization in the campaign to improve patient safety. Dr. Berwick introduced the term triple aim, care, health, and cost, into the healthcare reform discussion in his 2008 article in Health Affairs. Welcome, Dr. Berwick. Dr. Kitzhaber is the former Oregon governor and emergency physician. As president of the Oregon Senate, he authored the Oregon Health Plan and helped implement it as governor in 1995. During his third term as governor, he helped create Oregon's coordinated care organizations, which provide care to nearly 1 million people and could become a model for other states. In 2013, Modern Healthcare magazine ranked Dr. Kitzhaber number 2 on the list of the 100 most influential people in healthcare, and number one on the list of the 50 most influential physician executives. In 2013, Governing Magazine named him Public Official of the Year. Welcome, Dr. Kitzhaber. And these three powerful leaders will be moderated today, or he'll try and keep them in, corral them, by Dr. Paul Gorman. Is Assistant Dean for the Rural Medical Education at OHSU and Professor in the Departments of Medical Informatics and Clinical Epidemiology and Medicine. Before joining OHSU in 1990, Dr. Gorman was a primary care doctor in Astoria and served as Chief of Medicine at Columbia Memorial Hospital. He is now a medical educator and researcher and serves as the chair of the School of Medicine Curriculum Committee. Dr. Gorman, the floor is yours.
Thanks, Mike. Welcome, everyone. It's invigorating to see this much interest in this topic, making our healthcare system and our healthcare better. I want to get to the discussion right away, but just a few comments. First, disclosure, then format, then ground rules. So, by way of disclosure, I'm the moderator, Paul Gorman. I work for Oregon Health Science University, but nothing I say should be construed as representing the university. I'm here on my own. Second, I'm a member of Physicians for a National Health Program. I'm a strong advocate for single-payer care, and I've been working for universal care in Oregon since Measure 23, for those that remember it. But my job as moderator is not to advocate, but to facilitate, which I'll try to do. The format today, we're going to spend, I hope, about close to 60 minutes with not a presentation so much as a conversation among 3 people who've come here to share their wisdom and their experience with us. So for about close to an hour, we'll talk about 4 main issues. I've asked them to comment on goals, what we want to achieve with our healthcare system, prior reforms, to what degree have recent and less recent efforts at reform gotten us to those goals, shortcomings, to what degree have our previous efforts at reform fallen short? Have there been side effects? Have they backfired? And finally, 4th, next steps. Where do we go from here and how do we get there? After we've had that conversation, and each one will respond to each question and then hopefully respond to one another and have some conversation about it to enrich that. At the end, when there's probably 15 or 20 minutes left, hopefully we'll have time for some questions from all of you. Ground rules for those questions. City Club members will help identify you, so if you have a question, let them know you have a question and they'll let me know. Then you'll have a minute to tell your question. For those that are familiar with the Mattis Hell moments from the Mattis Hell doctors era, everyone gets a voice, but you only get a minute. And I'll rephrase the question so everyone else has heard it. I want to remind everyone that there's many, many interesting things to talk about these days, but this forum is about healthcare reform. And so as moderator, I will exercise my prerogative to keep us focused and on track, and hopefully also on time. So, thank you all for being here. Let me pose the first question to Alisha first, and then each of the others will respond. Alisha, we had a question about goals.
Yep.
What's true north? Against what goals should we measure success?
Well, I want to kind of back up a little, because I think when we use the word we, my question is always, who is the we? Can you hear? You cannot hear. Tell me whether you can hear. Okay. Can you hear now? Okay. Well, I should probably also say that anything I say are my personal opinions and thoughts as well, and are not the opinions of OHSU, Volunteers of America, or the Kapuya Foundation. So I want to say that up front. I want to step back a little bit with the question, and I think that there's a more fundamental philosophical question that has to be answered, and that is, do we, whoever the we is, believe that health care or access to it is a fundamental, inalienable right? That's the first question. Do we agree on that as being the main and primary issue? And if the answer to that question is yes, if we believe that health care and everyone's access to it is as fundamental and important as breathing and eating, then I think then we've reached a point of convergence, and that's a good place to be. I also want to add that I think that if we also agree that our ability to get healthcare transformation and the system of healthcare improved, if we believe that it is inextricably linked to the strength of our economy, both now and moving forward, then we also, I think, are in a good place. So now to answer the question, I needed to preface it with that first. What is required for the healthcare transformation system to be good and to be useful? Well, it's what Dr. Berwick had discovered and had shared with us in 2008. The system has to be affordable, it has to be accessible, and it has to be adequate. And I think that the questions that will come up moving forward is, okay, with the Affordable Care Act, we have increased accessibility. I think we still have challenges around the areas of adequacy and affordability. And I would even argue that there's still some question about that accessibility. We've improved accessibility, but there is still yet more room for improvement. And I would also go back to where we started, this discussion of universal health care. The question is, in order for us to have universal health care, everybody must have health care. And not everyone has it yet, so we haven't quite yet achieved that. But if we go all the way back to Franklin Roosevelt in 1934, I'm also on the Oregon Historical Society, so I'm gonna give a little bit of a history lesson. 1934, when Franklin Roosevelt, pushing forth his Social Security legislation, made mention of universal health care or national health care system, and boy, he was shot down. Actually, the Joint Ways and Means Committee came back to him and said, you've got to strike this or else you're not gonna move things forward. So that was cast down. It was not popular. And then you move to 1947, when you have Harry Truman, who also at the time had Congress who was poised to move with him in this idea, right, in this philosophy of everybody who has a body deserves health care coverage. The American Medical Association actually was very good in helping unseat many of those Congress members and said, no, we're not ready for that conversation right now. And then we move forward to 1965, where we then get the Centers for Medicare and Medicaid under the direction of Lyndon B. Johnson. And that was really important legislation because it then took a subset of the population, both the elderly and the poor, and said we're going to take care of them in a meaningful way and coordinate their efforts and make sure that we are able to control costs and improve quality of care for them. And that's questionable as well. But then we skip forward to the 90s, and then the 90s is where President Clinton at the time had wonderful ideas about healthcare transformation, but it was too complicated. It was too, it wasn't communicated very well. So there's that national story in the 90s, and then we've got our Oregon story, which I'll let John talk about. But at the time, Oregon was leading in that effort. We had the Oregon Health Plan, which expanded Medicaid, the access to Medicaid coverage for the population, and it did fairly well. But again, there's this issue of cost and cost containment. Very good ideas, but how do we contain these? And then we fast forward to 2010 to the Patient Safety and Affordable Care Act, which accomplished probably is the single most powerful piece of legislation, comparatively speaking, to Lyndon B. Johnson's CMS development back in 1965, that moves us closer to this goal of universal health care, but it's near. We're almost there, but we haven't yet reached it. And the reason I take you through this brief history lesson, and I'm coming to a close because I know that you said we had 5 minutes for responses, but the reason I wanted to take you through that kind of brief history lesson is because I believe that within our nation's history, there has always been the subtext has always been, everyone deserves health care as an American right. It's never been explicitly stated, but there has always been sort of this underlying sort of desire, and it was demonstrated by Franklin Roosevelt back in the 30s, and by Truman, and then by Lyndon B. Johnson. There has been this desire. And now I think it's time for us to really act on it and to be intentional and to figure out how do we first get everyone covered, because that's the goal. We cannot achieve universal health care unless everyone has access to it. And I'll say this lastly. Right now, we don't have a healthcare system, we have a healthcare market. And I'll say a little bit more about that in my future reply, because I also want to talk about the economics of it. But to conclude, I'll say this. In America right now, it's interesting, I want you to think about this. The condition is, if you have a car in America, you're expected to have insurance, right? Right? Now, where are our priorities? So you can speak to me, we're in a church, so we do call and response in church, right? So if you have a car, the expectation is that you have insurance. Well, if we applied that same logic, and this may be too logical, I know I'm risking being too logical here, but if you have a body, who in here does not have a body? Who in this world does not have a body? The same principle, if we applied it, if you have a body, then you should have insurance. So it goes back to, you can clap for that, yeah, thank you. So it gets back to my original fundamental question, which is a philosophical one. Do we believe that health care is an inalienable right? And if we do, then I think we've got what we need in terms of moving us and compelling us forward to move towards universal health coverage. Okay, thank you.
Why don't we go in order? I was going to ask Don, yeah.
Thanks, Paul. Let me first thank City Club and PNHP and all of you for the chance to share thoughts with you. I'm delighted to be here. What a beautiful place and a beautiful day. And it's an honor to get to know Alisha and be on the same platform as she, and to get to be with a longtime friend and a very admired mentor of mine, Governor Kitzhaber. I think he's done a lot for America, and it's a pleasure to be here with you, John. I mean, with Alisha's comment, all I can say is, wow. I mean, that was an eloquent and comprehensive statement. I guess I can't pass because I'm supposed to answer the question, but I agree with what you said. The way I would think about aims would be this. That aim 1 is the same as you said, which is healthcare is a human right and must be made so in the last developed nation on earth that has not yet done that. And it should be unequivocal and central. And one of the gaps I feel in public discourse is now our leaders, both on the left and the right, are mincing words a little bit about that. And I just put my stake in the same ground as you did. That's the aim, one aim, that access to the properties of society, the enterprises that help you stay healthy, should be a human right. Now, the next level down below that is the triple aim that Alisha also referred to. So that actually was not my creation. Colleagues of mine named John Whittington and Tom Nolan invented the notion in 2008, and I got to write the paper. Shows you the world's unfair. But John and Tom were asking a deeper question, which is, okay, if we're there to meet social needs, what's the need? That's just the first question anyone in my field of quality asks is, what need are we trying to meet? And they say, well, there's really three needs. One is that if you need care, it's going to be terrific. The best possible individual care, continually improving, and all the dimensions the Institute of Medicine laid out: safety, patient-centeredness, timeliness, efficiency, equity. You have a right to count on care the same way I have a right when I got on the Delta Airlines flight out here. I had a right to count on landing safely. And we're nowhere near that. So one aim on that score would be, for almost every dimension, we should be aiming for like 2 orders of magnitude improvement. Right now, the injury rates for patients in hospitals are about 1 in 10. We shouldn't be satisfied with 1 in 1,000, but we should aim for it. And for every one of the dimensions, we can talk about that. So much better care. The second of the AAAs is better health, because health care determines only 10% of your health. Your genes determine about 50%. 40% of your health is determined by things other than your care, like what you eat, your exercise, the environment, your race, your wealth, the presence or absence of poverty in the environment, violence on the streets. And I think we need to reorient around a system that can actually help us stay healthy, and that's the second aim, and that's my vision. And we should regard the budget for pursuit of health as including pursuit of those properties. And then the last is cost. And here I have very strong feelings and probably too strong rhetoric, but I now know so much that I wish I didn't about the levels of waste in healthcare, about what the money we spend that doesn't help anyone at all because the system's set up the way you said, not logically. The waste levels are phenomenal, of the order of about 1/3 of what we're spending. So we're getting to $3 trillion. So we're talking about $1 trillion a year that isn't helping anybody. And the problem here is confiscation, that's what I was talking with John about last night. The money comes from somewhere. It only comes from one place, that $1 trillion of waste, it only comes from workers. There's no other source of the money that healthcare uses than labor. Think of it. If it goes through taxes, it's coming from taxpayers. If it's coming from employer insurance, it's coming out as alternative to wages. It's the only source. And that money has lots of other uses. In the private sector, making your family well and thriving, in a company, competing in a global marketplace, and in government, building the housing we need, building the roads we should have, ending the criminal justice scandal in the country, working toward a just and equitable society. We need the money, and healthcare does not have a right to it. And so my vision is lower cost because we don't have an entitlement to money that we're wasting. My target for the country, I've thought about this, I think we should have a 15% of GDP target within the next 5 to 8 years. It would be a major dislocation in our economy, but one we need to swallow because the positive benefit of that would be enormous. So that's my take.
Thanks, Don. John. Great.
Well, I'd like to thank the sponsors for inviting me to participate today. It's very exciting to be on a panel with Don Berwick. Some of you may not know this, but when Don was the administrator of the Centers for Medicare and Medicaid in 2010, early 2011, he is largely responsible for Oregon getting the waiver and $1.9 billion. And it just wouldn't have happened without Don being in that place. And so, the 1.1 million Oregonians who have care under the new care model have Don Berwick to thank for that. So thank you again, Don. So this is an interesting question, and I'm going to start out and then end with a somewhat controversial statement that maybe will stir up my other panelists here. So I think, obviously, if we want to be successful in terms of reform, we need to agree on what our objective is. And so one of the fundamental questions to me is whether our objective is to finance and deliver medical care or whether our objective is to keep people healthy. And if we can agree that the purpose of the healthcare system is health, not simply financing and delivering medical care, then there are a couple other things we need to realize. The first one is that healthcare is not necessarily synonymous with health, although we have a system that believes that. Healthcare is a means to an end, not an end in itself. I don't know anyone who wants attenuated flu virus squirted into their arm. They just don't want to get the flu. So healthcare is a means to an end, not an end in itself, and healthcare has no intrinsic value outside its relationship to a positive health outcome except as an economic commodity, which is largely what it's treated as today in the healthcare market. So that's point one. Point two is that when you look, and Don alluded to this, if you look at those things that have the biggest impact on your lifetime health status, healthcare is not very important. It's like 20% maybe. 30% is genetics, and the other half are socioeconomic issues, whether you have an education, a job, your income, whether you have social supports and stable families, lifestyle and behavioral issues, whether you eat right, whether you exercise, whether you smoke, whether you take care of yourself, and the ability to make responsible lifestyle choices is also impacted by people's socioeconomic status, and environmental factors, the safety of your community, whether you have good housing. So my point is that if we focus this reform effort just on giving people access to health care and ignore the social determinants of health, which are far more important in improving the health of our society, we're not going to get from here to there. So I would say that the objective would be universal access, and access is different than coverage. Coverage deals with the financial barrier to access, but there are other barriers. There are language barriers, there are cultural barriers, there are transportation barriers, there are barriers in rural parts of the state because we don't have adequate providers. There are barriers if you're working a minimum wage job and your doctor's office is open from 8 to 5 and you're working 8 to 5, you have to take a day off and you can't afford to do it because you can't lose that income. So universal access to a defined set of effective health services that are linked to positive health outcomes and universal access to those social supports and economic opportunities that are critical to improve the health of individuals and of communities. So I just want to make one comment on the healthcare as an inalienable right. And I believe that, but I would phrase it differently because I think phrasing it like that narrows the scope of the conversation. I think it would be more appropriate to say everyone in America should have an equal opportunity to be healthy. Now, what does that mean? That implies that everyone should have the right to a certain package of effective health services. I mean, why should someone have a right to services that are not effective? Why should someone have a right to determine the sex of their unborn child with an ultrasound when the only diagnosis is curiosity? Why should someone be able to destroy their own bodies and then expect the healthcare system to come in and rescue them? So, universal access to a defined set of effective health services, but it also implies that we have an inalienable right to good housing, to good nutrition, to economic opportunity, to child care, to early learning, to education. We leave that out of our definition and focus just on giving people access to health care. I think we missed the ball game. And finally, it implies that everyone has a certain individual responsibility to do the very best they can to make the kinds of choices and decisions that will help preserve their own health without having to get involved in the medical system.
Thanks, John. Before we move on, any comments or reactions?
Yeah, I just want to say that you actually just proved my point. I mean, to say it differently is the same thing. We both believe that it should be a fundamental right, healthcare, and I think access is the first step, at least making sure that people have access to it. But I think that you can't really get to improving quality or even improving cost if you don't at least make sure that everyone is covered. So I think that is a fundamental first step, and we haven't achieved that yet.
I agree with you, but my concern is that by simply ending the conversation as everyone has a right to health care, I mean, I can tell you how many times in the emergency room I saw people who had access to health care, and then we sent them right back to the lousy housing, to an unsafe neighborhood, to an impoverished community where there was no opportunity. So all I'm saying is that I think we need to say people have an inalienable right to health care and to those social determinants of health that together produce the outcome that we want for our citizens.
Yeah, no disagreement there.
Let's take a minute with this and explore the implications of what John's saying, because we agree. There's a virus just appeared, and if it infects a child, it has devastating consequences. It will cause I think it's a 7-fold increase in school failure. It'll increase healthcare consumption costs by about 4-fold. And I think it increases prison because of the behavioral consequences, imprisonment by about 6-fold. So would you vote for a vaccine as to stop that virus as part of a health benefit package? Raise your hand if yes. But I made a mistake. It's not a virus. It's adverse child experiences, the ACEs score. And an ACEs score over 4 in a child has I think the statistics are about correct. And yet, what do we put into the outreach to the causes of toxic stress in children, seeing violence on their streets? Look at the list of what's on the ACEs score. We don't have a way to take our capital and move it from the ineffective care that's rampant and which people make a lot of money into fighting that outbreak.
You know, the risk profile of people who end up in the medical system with chronic illnesses, and the risk profile of people who end up in our prison system, and the risk profile of kids who aren't reading at 3rd grade are exactly the same. It's these adverse childhood experiences. And I guess the point I was making, I think we're all making the same point, maybe we're beating a dead horse, but unless we as a society redeploy some of the resources that are currently being spent in our medical system and put those on the front end, we will forever be chasing our tail and paying more money on the back end.
Paul, I'd like to just one last. I'm
Sure,
sorry, 'cause
one more.
I just want to make
Then
this
we have
point.
to move on.
Yeah, we will. My point about access is this. So I work at the community level. I work with a large reentry population of folks who have who are dually diagnosed. These are patients who have been in jail, who have a mental health diagnosis, who also have substance use issues, and who struggle with houselessness. So it is a trifecta of comorbidities, okay? And one of the main things that I see from the ground level is that when folks don't have at least access to health care insurance, they cannot get access to the services that they need. And this is my fundamental point. We are not disagreeing, and it's not limiting the conversation. It's the first step, in my mind, to the conversation. When you're dealing with folks in front of you who have a very immediate need, and they don't have Medicaid coverage because they just came out of jail and they lost it because they went into jail, we have a problem, John. And so I'm saying access has to be the beginning. I didn't say it was the end. You added that part. But it definitely has to be the beginning of the discussion. And so I just wanted to make sure that I'm very clear, but I also like to have a good, healthy, hearty debate. So thank you.
Thank you. So I'd like to move the discussion on now. I don't think it's a dead horse. It's a very healthy horse, and we've been giving it the attention it needs. But now let's move on to reforms. The next question. I heard, in terms of goals, I heard affordable, accessible, adequate, universal. I heard talk about social determinants that need to be addressed. And those are the main points I heard: universal access and getting to the triple aim. So if those are the goals and we agree on them, and the one thing I heard across the board was human right. We have a right to this thing. We disagreed a little bit about what the thing is, but we have a right to it. So now there have been reforms just in my brief and checkered career since DRGs in 1981, which was an incentivization of hospitals to reduce costs, to the ACA in 2010. We've had a series of reform efforts at the national and local level, and I wonder how well you believe those reforms have gotten us where we need to be. And let's start this time with Don.
Well, let's start with the good news. The Affordable Care Act, which I was responsible for implementing about 70% of the provisions during the time I was in CMS, I give it a pretty high score compared to the prior status quo. The numbers are important. As is written, the Affordable Care Act, if fully implemented, would have covered about 32 million people of the 50 million who don't have insurance in our country. Because the Supreme Court watered down the Medicaid expansion by preventing the government from enforcing Medicaid expansion on states, that left 19 states out of expansion so far. And through a number of other provisions, unfortunately traceable to the court in some significant measure, we're at only 20 million That's about half the population of England. I mean, it's not bad. We've got half a country covered, 4 times the population of Scotland, who didn't have insurance before that. So, I mean, I think we should be throwing a bit of a party on that one, that there's a lot of your neighbors who have coverage that didn't have it before. Kids under 26 covered under their parents' policies, the forbidding insurance companies from failing to issue policies due to pre-existing conditions, that's gone. Lifetime limits on coverage are gone. And a lot of enrichment of the benefit structure. In Medicare, for example, you may not know this, but when the 1965 law was passed, Medicare was only a hospital coverage system. Was not for prevention, was specifically not included in Medicare. Now it is. The Affordable Care Act added very strong prevention benefits, first dollar coverage. So I think as a step toward universality and human rights, pretty good. There's some provisions on transparency that are helping. And a sleeper that I don't know if you all know about, but it's this innovation center, the one that John mentioned. I got to set up the Center for Medicare and Medicaid Innovation, CMMI, which has $10 billion over 10 years to invest in experiments. The reason we were able to get support to Oregon is because Oregon was proposing under John a very exciting new way to think about healthcare delivery, and the Affordable Care Act gave us the leverage to be able to say, okay, we want experiments like that will achieve the triple aim. So that's all to the good. There's bad news. Should we stop? You want the good news first only right now, or you?
You know what? Let's go ahead and mix them up, because for time.
All right, very quickly. Here there are really big gaps, though, and I'll recite them. I won't speechify them. I'll leave that to my more eloquent colleagues here. We have 50 million uncovered. We covered 20 million. There's 30 million. They're there. They're human beings. They're people in Medicaid non-expansion states. They're people who haven't yet found their way onto the exchanges. They're undocumented residents here, aliens who live here but are human beings, and a civilized society should be making sure they have health care. They need it. It's a disadvantage to us to keep it from them. So there's pretty big excluded groups in our country right now, and I'd like to get, how about the rate of no coverage should be 0 in America, not 30 million people. The Affordable Care Act it was a compromise. We kept the private insurance system. The Affordable Care Act was a way to use the private insurance system through exchanges to cover a lot of those 20 million, 30 million people. And there was a bit of a buy-off going on. So insurance companies have done very well, thank you. They'll complain in some markets, and there's certain problems with some subgroups, but overall, just look at the stock market. Just watch what these insurers have done. For example, Medicare Advantage was supposed to have cost reduction in the Affordable Care Act. Instead, every year, Congress has given Medicare Advantage more money, in direct contradiction to the law. So the power of the insurance lobby is phenomenal. With respect to investments in prevention, they've proved quite vulnerable. We do have some good prevention work going on, but the first thing Congress did when the law was passed was take a big swipe at the prevention fund that was set up under CDC. I think it got halved, or was close. They were aiming for that. They would have zeroed it out if they could. Transparency's been incomplete, and we can't function without knowledge. Not for blame, not for reprisal, but would you drive your car at night without headlights? Well, if we don't have the data on how things are going, we can't do very well. And just read the papers. I can get into the details here and bore the heck out of you, but we are too uncommitted yet to transparency. And finally, everything John and Alisha were talking about around social determinants, still only a quarter of a loaf, not even half a loaf. We have not become a country invested in interrupting the generators of ill health, or helping people do that. So we have a lot of work left to do. I could keep going on that, but I think I'll stop on those, and we'll get to other problems on the table later.
Okay, thanks. John, your comments on efforts of reform and whether they've got us where we want to go.
Well, they haven't got us where we want to go, but they've definitely moved us quite a ways in the right direction. So I'll go all the way back to 1989 when we enacted the Oregon Health Plan. And the objective there really was to try to develop a floor, make a command decision about those people who couldn't afford the cost of their own health care to make sure that they were covered with public dollars. And in 1989, we passed a law that said anyone who had an income up to 100% of the federal poverty level should be eligible for Medicaid, and they didn't have to fit in one of the federal categories, which is essentially what the ACA did 22 years later, but it went up to 138%. And the second thing we did was recognize that healthcare is not necessarily synonymous health, and build a benefit based on a priority list that tried to connect health services to their value in improving the health of the entire population being served. So we were ahead of our time in a couple of ways. What it didn't do is it didn't try to demand outcomes and quality. It was more of a benefit design coverage exercise. But millions of Americans have benefited from that. I see Vicki Yates back there, one of the original gang of I don't know how many. Raise your hand, Vicki. She was there in 1989 working on the Oregon Health Plan. Millions of people have benefited from that since it was implemented in 1994. Then 2011, the coordinated care organizations, I think, have also been tremendously successful. They were based on the premise that we should refocus on community and population health, that we should operate under a global budget that grows at a fixed amount per year. So they grow at 3.4% per member per month. They can't exceed that. That they have to have very strict outcome and quality metrics. That they ought to be able to use federal dollars to spend on things that aren't traditionally considered health care, but actually improve health, like community health workers, for example, or maybe housing. And finally, we push the accountability for health and cost to the local level. We have 1.1 million people in that model today. They're all operating within their fiscal constraints, and they're turning in remarkable health outcomes. Reduction in ED visits, reduction in hospital rehospitalizations for congestive heart failure and asthma. A lot of more kids are getting developmental assessments before the age of 3, and the list goes on. So that's been very, very successful, and I think the ACA pushed a lot more people into that care model with Don's help. We've reduced the number of people without insurance in Oregon from 14% down to less than 5%. And as Don said, 20 million Americans today have health insurance coverage that they didn't have on January 1st, 2014. And that really is a huge, huge accomplishment that we should certainly celebrate. I think the problem, as Don said, is that there are still gaps. Some of the people that have insurance are experiencing a huge increase in deductibles, which are going up 4 or 5 or 6 times faster than wages. So many people who are insured, for all practical purposes, aren't. And I think the other thing we need to do, and I think we need to do coverage and delivery reform simultaneously, not sequentially, because even if you have everybody covered, unless you address the fundamentally perverse incentives in the delivery system, you can't control cost or improve quality, right? And unless you take that on, it doesn't matter whether you have a single payer system or private commercial insurance or Medicare and Medicaid, you're paying for the same inefficient, hyperinflationary, ineffective healthcare system. So I would just say that we need to redouble our efforts to get everybody under the tent, but at the same time, to keep them under the tent, we've got to take on delivery system reform.
Okay, thanks.
So I think that we've made some tremendous strides. I think that there are a few things that I wanted to point out. The Affordable Care Act did a very nice job of offering a public option. And that public option then sort of helped the market, right? Because you've got private insurers who have their costs set, and this is sort of economics 101. When you saturate the market, you create competition, you force people to have to lower their prices, right? Or at least consider it. And so it did a nice job of that, of forcing the private sector to think about how they price and it also expanded what I think all Americans love is this idea of choice. Whether it's a good one or a bad one, it expanded the opportunity for that. So with all of that, I don't disagree that there has to be this component, and I think it's, I started at the beginning talking about it has to, in order for healthcare to be useful, it has to be affordable, it has to be accessible, and it has to be adequate. So it doesn't ignore these other components. In order for it to be adequate, what we're dealing with is the quality aspect of it. We're saying that everyone should be able to you should be able to get the right care at the right time by the right person every time. Right? That is the goal. We have not reached that. There are many gaps. It should be affordable in terms of cost. There are a number of folks who have insurance but cannot afford the deductibles, or even in some cases, they are cut off with how many visits they can see a certain specialty doctor. And then that gets to the adequacy question. So there are still very many gaps. And we haven't really talked about all of the things that have driven some of the high cost. We are a free society. Technology has been super important in how we do business. It has become a prominent centerpiece and feature in much of healthcare. And some would argue that the information technology, IS world, and the advance of technology has increased cost in a way that is problematic. There was a book that I was reading by Tom Daschle, and he basically had this pyramid, and the pyramid had primary care at the bottom as the foundation and specialty care at the acme, or at the peak of this pyramid. And then he compared, on two sides, he compared the United States of America to other countries. And he said that other countries understand fundamentally that primary care should be the base and the point at which we all operate from. Everyone should be able to go see a primary care doctor and get preventative care services. And then if they need specialty care, to get it. And he also added technology at the top with the specialty care. But then he showed the United States of America compared to other countries, and it started from the top to the bottom, so that we are really in reverse, inappropriate order, where right now, if you needed to see a cardiologist, you could probably get in to see a cardiologist before your primary care provider. And that's because we've got a workforce issue. We've got a supply and a demand issue. So there are a number of things that I feel like still need to be resolved, right? So there's accessibility, but there's still many areas in this around affordability and around adequacy. And I would also say accessibility. The other thing I would say is that, again, we keep saying healthcare system. I'm not really convinced that it's a system. We have a healthcare market. And in a market, there's a very clear top and a very clear bottom. And in a market, there are certain people who get to access that market more readily and more robustly than others. And I think that if equity is the goal, and equal access is really the chief universal goal, then we've still got a lot of work to do in that area. But the Affordable Care Act was a nice, rich, forceful next step in helping us to achieve that.
Do you have any reaction, any of you, to one another?
Hear, hear.
Well, we've talked a bit about whether the reforms have succeeded, and mixed in a little bit of ways in which they've fallen short. I'm curious, Dr. Gelman and Dr. Gelman taught me about balancing measures in improvement science. And balancing measures, if I understood correctly, we're measuring one thing when we try to improve things, and sometimes something else changes that wasn't what we were planning on. I wonder if, when you think about the reform efforts that we've had over the last decades, or a couple of decades, have we seen side effects? Have we seen inadvertent adverse effects of the healthcare reforms that we've tried to implement? Any thoughts about that?
Well, I can tell you one. I can give you one. This is not a systemic problem, but when the Medicare Modernization Act was passed in 2003, which added a prescription drug benefit to Medicare, the drug industry was able to insert into that bill language that prohibits Medicare from negotiating prices with the drug company, something every private sector company does. And if you add up Medicare and Medicaid, you have a huge number of people that you could use to drive down pharmaceutical costs. And that has got to be fixed. And I'll just be very short here, but I was looking today at the stock health of Gilead, which is a company that produces a hepatitis C drug, which is marvelous because it can cure hepatitis C at the cost of $90,000 for a course of treatment and maybe a second course of treatment. This year, they are supposed to make somewhere around $17 billion in cash flow, and I could be off $2 billion up or down, but that's in the ballpark. They're spending 20% of that on R&D, and get this, 45% buying back their own shares to increase the value per share and give a bigger return to their stockholders. That is obscene, and that needs to be called out, and I think whoever is elected president, a priority really needs to be made on getting that language out and using the purchasing power of the public sector to drive down those costs.
Thanks, John. Any unexpected adverse effects from your point of view, Don?
Some. I think we can start with pharmaceuticals. We're out of control now. It's not just the specialty drugs. The prices of insulin have risen not just year on year, even within years. So have insulin strips. The pharmaceutical industry is now in a spiral of increase that I don't think we've ever witnessed before, and there's no control of that yet has been proposed. Secretary Clinton in her campaign is proposing a certain set of moves on that. Presumably, maybe the other party might, I suppose, but we really can't. I don't think we can sit there that much longer on this. It's denying people access to meds they need, and since so much pharmaceutical purchases involves co-payment, so we didn't do pharmaceutical reform, and that they're enjoying that. As I said, pushing back on the insurance industry, the Medicare Advantage story, I personally, this is controversial, but I really think Medicare Advantage should have been pressed down to the ordinary Medicare levels or lower. After all, it's supposed to be well-managed care, and instead the opposite's been happening, and I think that was a political, it was the consequence of the politics of the Affordable Care Act, maybe not unanticipated, but certainly unwanted. John said that there's a balance here between financing reform, which we need to get the coverage that we're all talking about, and delivery system reform, and that's pretty wonky language. Delivery system reform isn't. I mean, it's sort of simple. It's like the care you need to help you stay healthy if you're well, to enjoy your life if you have a chronic illness. You could describe it. It's not so hard to describe. You probably want a team involved. You want respect for your own preferences. You want the use of the community resources that you're linked to as part of the whole picture. You'd like, if you have mental health issues, you want to make sure those are incorporated into your plans. You could describe a kind of holistic, community-centered, home-based, respectful care. It's not what you have. You have care in institutions and events. And we will never get where we want without pushing hard on the delivery system change. And what we're assuming is the market can do that. If we set the contingency right, the market will surface with these reforms. And I think there's a better way. The rest of the gaps are pretty technical. We didn't do anything on telemedicine. And I think that's a big, wonderful area where telemedicine and telehealth could create part of the future that we really want, that's as easy to use as most of the rest of your life. Why is the electronic record not more like a cell phone? And it's not in the law. We didn't do that. We're starting to fix it, but we got ways to go. And then, well, we'll talk about single payer, about what's creating the option for state.
I just want to ask, Dr. Moreland-Capuya, what about you? Do you see any side effects, adverse effects, backfires in the reforms?
I do, and from the ground level, I think it's really important, again, it's an important discussion to have about the finance and the delivery, and I want to focus on the delivery end of it. You know, when the ACA was passed, there were these specific measures for the goal was for agencies to have an electronic health record because it will create greater efficiencies. And again, that makes sense, right? You would think. But here's how I want you to kind of think about it. So I eliminate the clerk in the front room who does the medical records, but then I've got to add 2 staff to my ITIS department to make sure that my EMR doesn't crash. So then you ask yourself the question, if I traded 1 for 2, is that efficient? I'm asking a question. Is that efficient? I don't think so. Just basic sort of reasoning, right? Or we say, okay, it's going to be more, efficient for us to make sure that we are coordinating our efforts, which is important, and that we've been giving a very important role for what integration should look like. And there are prerequisites to integration. And we say, okay, you psychiatrist and you primary care physician, you all need to be working together in one place at least, and then eventually find some time to get on the same shared medical record, and then eventually communicate enough with each other so that you don't have the patient coming to the same facility that you both work at 3 times during the week when they could be seen all in one day. If we had better coordinated that effort, and if we had the systems and structures in place that would allow for reimbursement of services. I think we are moving in that direction with CMS, but we still have some challenges there. So I think that what we have seen is that I think that the intentions have been great. I think that it has capacity, this ACA has capacity to be wonderful, but there's a lot of fine-tuning, and the fine-tuning has to be considered at the patient level, because the question is, how does it impact the patient? We can have all these wonderful policies and procedures and expectations for what the service or the delivery of service should be, but on the ground level, how does the policy play out? And there have been tremendous side effects. And the other issue that I want to highlight again is that we've got an issue, at least in this state, where we have folks, some of our most vulnerable folks that we're trying to serve, and we're trying to get ahead of the curve, and we're trying to keep them out of prison, and we're trying to keep them out of the emergency departments, and we're trying to get them to make more effective use of their primary care providers in their health homes. They slip up because that's a part of this relapse prevention and recovery process. They end up in jail. They don't have a house, so then they lose their coverage. It's hard for them to gain coverage when they get out. They don't know how to navigate a big wonky system that was meant and developed to help them. And then we end up with more situations of greater hospitalization. So there is a lot. I think that CCOs, or the coordinated care organizations, are islands of excellence. But what I would like to see is a nation of excellence. And the way that we move in that direction is, I think that we've got to think about not just the larger policy, but how it's impacting people on the ground level. And I think that I've seen electronic medical health records are great, but they also cost a lot of money, and they also have a high administrative burden. The policy is great that you want coordinated care and for everyone to work with each other, but the problem is there are a lot of systems barriers to that, namely around billing and serving people. So we've got a lot of work to do in that area to refine these processes.
Okay, well, I'm sure we all agree with that. We've all got a lot of work to do. Thank you. So given that, and I think we're actually kind of in the same place about where we want to be, and the shortcomings, the gaps, starting from where we are, how do we get there? What are the next steps? Dr. Moreland Kapuya, I'll let you...
I just finished speaking. So.
Oh, all right. John, you want to... How do we get there?
Well, I think I couldn't agree more that federal action is needed to really get where we need to go, but I am not impressed with the agility of Congress to agree on anything. And so I do think that state innovation is going to be the pathway. It's clear if we can demonstrate, ways forward, that's much more likely to be adopted by other states as well. So a couple of specific points, and then I'll make a broader statement about single payer. So I think that in Oregon in particular, because I do think we have islands of excellence, we need to extend more aggressively and robustly that CCO care model into the private market, because this won't work unless we get it into the private market. We've done that a bit with the state employees under the Oregon Public Employees Benefit Board. We need to add the Oregon Education Benefit Board, so that's 300,000 people right there in the private market. And then we need to be able to list this option on the exchange as an option for employers. So that should be a high priority. Secondly, I think it's important that we prevent any more out-of-state for-profit companies from buying coordinated care organizations. The Centene purchase of Trillium down in Lane County shifts the focus from community-based care to feeding a shareholder out of Missouri, and that'll be the death knell to the coordinated care organization. So, having said that, a lot of these CCOs were part of the IPAs that were created in the 90s to take care of the Oregon Health Plan, and those docs who made the initial investments were in their 40s and 50s, and now they're in their 60s and 70s. And CCOs are valuable assets. So we need to give them a way to get cashed out, but not a way that basically piecemeals our experiment out of state. I think it's really important that CCOs begin to evolve from a hospital physician-centric organization to one which has as a part of its business model the redeployment of resources upstream in the community to begin to address the social determinants of health. And let me say, aspirationally, I think you can get from here to there. We've come a long way since 1987 to 2012. I don't know how many of you remember the Archimedes movement. A few of you there? Well, What we were trying to do there was a design exercise that essentially identified all the public dollars we were spending on healthcare in the state of Oregon: Medicare, Medicaid, and the value of the tax-deductible portion of your private insurance. And with that, we wanted to ask, okay, how could we create a floor for every last Oregonian? What would that benefit look like? And what would we have to do to the delivery system? And that one was snuffed when AARP came in and stepped on the air hose of the conversation because it involved AARP, because it involved Medicare. But I do think that the place we need to end up is a publicly financed floor, just like we do in public education. Every child, regardless of income, gets a public education. You can argue about whether it's a good education or not, but everyone is covered. And parents who want to give their kids more can use their after-tax dollars to get a tutor or send their kids to a private school. We need a publicly financed floor, a defined set of effective health services, and there's more than enough money in the system to allow everyone to have everything that could possibly benefit from them from a health care standpoint, with the ability of people who want to purchase more can do so with their after-tax dollars. That's where we need to get. We're almost there with Medicare and Medicaid. We're moving in that direction with the aging of the baby boomers. So I think the question is, what's the strategic steps that you can take at the state level to begin to tee up that conversation more robustly as part of the national agenda?
Thank you, Dr. Kitzhaber. Dr. Berwick, next steps, how do we get there?
That's some next. Well, the thing we talked about right at the beginning about setting aims and agreeing on them as a matter of social solidarity, to me, is key. And I think we need to be explicit, have the courage to be explicit. If we can't do that nationally, you should do it at the state level. But we articulated some of the dimensions of that, and I think you don't know how to get there if you don't know where you're going. So the aims are key. With respect to the next couple of years, I do think pharmaceutical costs are an urgent fire. It's hurting people, and we need an aggressive, courageous stand on that. Hopefully in some cooperation with the pharma industry if they'll go there, but this is not not optional. We've got to fix this. I think that, well, let's go to states. I felt in Washington, I feel here, that state experimentation is a real opportunity now, given especially Washington's relative paralysis. You may know I ran for governor in Massachusetts. I ran for the Democratic nomination. I'm not governor, so I lost. But, although last year I started.
Count your blessings.
I finally said up a few months ago, I actually won, but I turned it down, and I felt a lot better. But I did end up, I didn't start, but I ended up putting single payer on my platform. And I do think there should be some states that try single payer now if it's possible to have the architecture. We can get into the details, but I think we can have a mature public dialogue about the base that John's talking about. I think it would be far more efficient administratively. I think right off the top, there's probably double-digit % of the total expend that you get back because it's such a simpler system. So I really would like to see that somewhere. How about here? Short of that, as you know, Secretary Clinton's put a Medicare expansion on the table to offering it as a public option to people about 55 and older that failed in her 2003 try at reform, but the time may have come, and it's a step. Two other quick things I'll say. One is back to John's vision of these CCOs was world-leading, not just national-leading, and I think it's trying to get all of the resources in a pot for a population, and so some form of global budgeting in which you finally can say, I think I'll buy an air conditioner for that child with asthma, and it can happen, is a very important resorting of opportunity, and I would keep pushing that. If you can't do it with single payer, you can do it still by really digging in even further on this idea of globally budgeted, population responsible groups, not for profit. And then the last thing I'll say is, WHO has a brilliant set of guidance around what they call health in all policies, and we've talked a lot about social determinants, but this is not virgin territory. If we really want to start to think about every move we make on transportation policy, housing policy, education policy, criminal justice policy, as all related to building robust and vital communities, and if we have leadership, executive leadership and legislative leadership that really expects that, they want it to make sense, I think we can make some progress. So I'm looking for parts of the country that say we're going to take that global view of the generators of well-being and make that the public policy, and I think we could go a long way doing that.
Thank you. Dr. Moreland Capuya.
Yeah.
Next steps.
Yeah, so the question was the next steps in terms of achieving universal health coverage. And I think it's inherent in the name, universal. In order for it to be universal, everyone has to have it, has to have insurance. And so that's the first place to start. We haven't reached that. The next steps is to at least ensure that everyone has health care coverage, not independent of these other psychosocial components that we've discussed here today, but in lieu of, in parallel to. So that's a first step. The other thing that I think is important is, you know, it's interesting, Vermont came this close to coming towards a single payer system. And then they recognized, oh shoot, they didn't finish it, they didn't execute because they didn't know how, there was not a secure financial plan or financial basis to undergird the plan. So I think we do have to be, I do believe a single payer system is something that we should be working towards. I think we have to be mindful of how we do that. I think it also gets back to this very issue, and I want to go back to my beginning philosophical point because there's an arc, a beginning, a middle, and an end, and I want to go back to the beginning as my end. In order to achieve this, everyone has to agree and have shared definitions and an understanding of what we are actually trying to achieve. If it's universal health care, then how we finance that is important. Us agreeing on the fact that it should be financed is key. And then how do we deliver it? Should it be private? Should it be it's a publicly funded endeavor through taxes, but then it's delivered through private entities? Is it not-for-profit organizations that do it? Is it for-profit? Those things are all up for discussion and should be discussed. But I think that a primary beginning first step is at least getting everyone covered. We do not have that now. So the next step in my purview is it's real simple and basic. Let's at least get everyone covered.
Thank you. Comments and reactions, gentlemen? I think we're ready for questions. So the City Club members are going to identify folks that have questions and try and help me find you and get the right order. Let me remind you that this is a discussion about healthcare reform and not other things, and that we're going to use the mad as hell moment model, which is to say everyone can have a voice, but no one can have more than a minute. So, Mike, who's got a question back there? Go ahead and speak up, and the acoustics are very good if you speak up.
Adam Hoverman, family physician and day one preventive medicine resident at OHSU. We have the Olympics coming up soon, and it seems a worthy time to look back at the IOM report, Shorter Lives, Poorer Health, Stephen Wolf and others, where it shows that there is a clear health disadvantage in the US, even among those who are white, insured, college educated, with an income, compared to many other, 16 other rich countries. One of the calls in the report is that everyone should know this, that we're dying faster than our rich country peers. In light of what we have in the next couple of weeks, the Olympics as a competition of sorts, what country would you say we should keep in aim, clear in sight, for learning from in that regard?
I mean, if you basically look at the European countries that have universal coverage, and you look at their total spend, that is healthcare spend and spend on social determinants, we spend about the same amount in the United States as they do. But we spend a whole lot more on healthcare and a whole lot less on the social determinants. They spend a whole lot more on social determinants and a whole lot less on healthcare. How do they do that? And part of it, I think, is this notion of solidarity. It really is, if you go to Europe, they're all in this together. And it's an expectation. It's not seen as a burden. It's something that we do for each other as a community. So I don't know that there's one country, but I think most of those countries have got the secret sauce that we just haven't got yet.
I get to travel all over the world, luckily. I love it. And I would say I can't name one country. I wish we were that country in terms of health. There are a score of countries that are better than us on most dimensions of health and well-being. But I think behind your questions, a very important perception, which is to get what I've heard others call global brains. There is a sense of American exceptionalism around this question that somehow, you know, we're not Sweden, we're not Denmark, we're not England or Scotland. I know that. But wouldn't an intelligent human being with a tough problem go ask how others are tackling it? And I really think that we should not apologize, and we should not force our politicians to apologize for asking your question. And I'll tell you, we'll find great things. If you want to see a really wonderful enterprise around early childhood development, go to Scotland right now. The Early Years Collaborative is going to break through, I think, to a new way to think about preparedness for school and bonding in young people. If you want to see a very high-functioning chronic illness system, look at central Sweden or Singapore right now, trying to build out chronic illness care to a level that really would be good for any country. If you want to see prevention underway, look for the countries that have made tremendous strides in the public health arena. By the way, there's a book written by my friend Lord Nigel Crisp, who was the head of the British National Health Service, became a sort of internationalist now. He's written a book called The World Turned Upside Down, and he makes a really interesting point, which is if you go to some very low-income countries, developing countries, look at Kerala in India, or some of the progress being made in South Africa on HIV/AIDS care, or I've been working in Ghana on maternal and child mortality. You find innovations developing in resource-poor settings that have a lot to teach us, because they can't afford the waste. They have to figure out how to get communities engaged, and that reverse flow of ideas could be very robust. So my advice to Oregon: get global brains. Go ahead and look around and get an answer to this question in any dimension of care you care about.
Nothing? Okay. Okay, another question. Yes, over here. Sorry, this is very arbitrary. I apologize for that. I'm going to do my best. Sir. Okay. Okay, I'll read the question. What are the chances, what are Oregon's chances of qualifying for the Section 1332 Innovation Waiver under PPACA? And what is that's the long version of ACA. And what is the likelihood of achieving renewal of the waiver every 5 years, given the ability of HHS to change guidelines under each president? So can we get this waiver, and we'll be able to keep it if we get it?
Well, if we could get Don back at CMS, I think the answer would be yes.
And first, what's this waiver? What's a 1332 waiver?
It's one of the waiver authorities, and Medicare can say the state can go ahead and try innovations. The requirements are that OMB and the actuary in Medicare have to score it as essentially budget neutral. There has to be a belief system in Washington that it's not a scam, that it's not just a way to get more money. So the actual answer, the answer is absolutely yes. And if current CMS leadership were to stay there, the answer would be more yes. We've got some very good leadership there right now. Oregon's end of it is authenticity, which is, this isn't a game. And the kind of redistribution of resources that John's talking about, so we can go do the right things instead of the wasteful things, you have to mean it. And I don't know if that's too preachy, but it's, figure out what you want and what it could deliver, and promise that as part of what the offer to the federal government. You know, the job of the Medicare trustee or the actuary or OMB is to make sure that money is being used as well as it possibly can. That's their job, and that's the scrutiny to which these waivers will be subjected, absent other political influences.
I think the answer also is yes, and I think it's really important for Oregon to continue to emphasize the amount of money that our last 5-year waiver has saved not only the state but the federal government. It's a really big deal. It's over $4 billion of net savings to the federal government, and hundreds of millions of dollars that we didn't have to spend on health care that can be spent on education and a variety of other things. So it's important that we continue to articulate that this is not just a grab for more money, this is actually saving money and improving quality.
So the question is, are we talking about health as the absence of disease, or are we talking about health in a more holistic way that includes connection to community, connection to other people, and all the other aspects of health that we might include? And I heard a related part is, to what extent does the separation of those discussions parallel or even feed into separate conversations at the policy and industry level, a food industry and a health industry that aren't connected in some way. I think if that's close. So let me ask you all to comment on the connection between nutrition and health and the way we think about it.
Yeah, so a very good question. Your latter response about health being all-encompassing and more about wellness, that's the World Health Organization definition. And it's a nice, I think, working definition that many folks who are on the ground working in an integrated setting do believe. There are many practices that have integrated naturopaths and dietitians, osteopaths and allopaths into the care, recognizing that who we are dealing with is a whole person, that the body is indeed connected to the head, and that those things are important. So definitely in my practice, we consider all of that, and wellness it's a state of being. It is the ability to pursue happiness and to gain fulfillment in all the areas of your life around professionalism, relationships, spiritual fulfillment. It's all of the above. So definitely we take a holistic approach in the community settings in which I operate.
I would agree. I think the definition of health is overall well-being, not just the absence of disease. And actually, taken up just to the policy level, part of our vision here in Oregon was not just the coordinated care organizations, but were the early learning hubs, which essentially are designed or initially designed to make sure that kids were basically reading at level in third grade, which requires wraparound services, mental health services, family support services, and there is an interface occurring with some coordinated care organizations and the early learning hub. So, I think it's Lynn County. The CCO is the early learning hub. And if you go around the state, family care up here in Portland, all care down in Grants Pass, they're actually beginning to build those partnerships. And I'll just conclude by saying I think this gets back to Don's point. At the end of the day, it's the community aspect of these things that is powerful. That we can set the sort of the high level policy, but it's figuring out those ways of integration and engagement at the community level that's actually going to produce that kind of a definition of health.
Thanks, John. Don?
Yeah, just briefly, this harkens back to this health in all policies idea, which I think is a really, really powerful and important idea. It's not a throwaway. So for Oregon or for Bend or Portland or for a governor, I would say get everyone around the table and understand how it's all affecting this kid in terms of nutrition. Because it is transportation, it is housing, it's not going to be one thing. And I think thinking holistically is the challenge. It's the challenge of our era, really, instead of in fragments. I was on the Navajo reservation last month where obesity is rampant and nutrition problems are severe, and the food supply chain isn't up to the task. You can't find a trading post with green vegetables. They don't have refrigeration. That's going to take a comprehensive approach. And the Navajo leaders that I was speaking with used an interesting term to me that maybe you could use. They call it food sovereignty, which means to understand that as a matter of public policy, to take control of that issue of supply chain and total nutritional resources as a matter of policy at some aggregate level, and say we want it right for our kids and ourselves. Let me make two other quick points. One is underneath our conversation, I have a belief, which maybe John and Alisha will not endorse. I think a lot of this is about poverty. That it's not true that better off people, of course, have nutritional problems. Obesity is not confined to the poor. But if you take any one of the risks we're talking about and you map it back, income inequality and poverty it's a big root of this. And I think that a healthcare enterprise and advocates who mean it are going to have to be advocates for the relief and elimination of poverty. And I think that will be a route to some of what you want as well.
Thank you. Alisha?
You had some questions on the page.
I'm sorry?
The questions on paper, I saw a few people.
I've got some more. Let's go to the paper question. So here's one. Can you envision a single-payer system coming to Oregon through the ACA waiver? And can CCOs function within such a system?
Well, let me answer the second part. They can certainly function within the system. Right now they get paid from, the dollars come from Medicaid. So I would say that CCOs are a single-payer system right now, right? So I think the real question is how do you move that model into the private market. So I don't know whether being able to do that involves a federal waiver as much as it involves a change in state policy. But I'd be interested in Don's view.
No, I think it's possible. The authority is in the ACA, but there are big barriers that Vermont meant. The barriers would include getting Medicare to play. Medicare stood aside in the Vermont proposal, and that it'd be much better if Medicare joined in a single-payer effort. There's ERISA problems. I don't know how big they are here, but ERISA is a pretty toxic policy environment for consolidating budgets. It means that the self-insured multi-state employers can take a pass. And I don't know what percentage of Oregon coverage is probably self-insured. But
It's large and it's growing. And in fact, it was ERISA that derailed our employer mandate back in the 90s.
The problem with ERISA is it's statutory, and the only way to mitigate it would be new statute in a Congress that is having a lot of trouble being Cartesian right now.
But and I don't disagree with that at all. I guess the other way to look at it is if you could prove out, if employers really believed that they could take the CCO model with those outcomes and a fixed growth rate of 3.4% a month, that's probably a lot better than they're getting as self-insured. So the question is, how do you begin to have that conversation so you don't have to fight them on ERISA? They want to move in that direction because it's a lot more cost effective. It gets rid of the,
Well, I would say that, I'll be more optimistic. With the CCO experience you've now got under your belts for, 5 years is it now?
way over 5 years.
You've got probably one of the best platforms in the country for taking this forward in a delivery system that could step up to the challenge.
Okay, I've got another one of the submitted questions. I thought I'd do another of those. Since this is a workforce issue, how does the education of primary care clinicians fit into this? MD, DO, nurse practitioner, physician assistant. And let me add two things, just that my personal additions to that question. One is my first trip to Oregon was for the new primary care residency program in 1979, and we're producing fewer primary care physicians now than then. And second, a Mayo study just showed that more than 50% of physicians have at least one symptom of burnout. And so I want to mix that. I think burnout in primary care scores pretty high in burnout. So your comments about how we can work on the workforce, how we can improve the workforce, especially in primary care.
So I actually mentioned this at the beginning, that it's probably easier for you to go see a specialty care doctor before you can get in to see a primary care doc. And I think that a lot of it, there are a number of things that I think we can do to improve the workforce. One is I want to take it to sort of a different direction. Right now with Medicare, there are limitations on who can bill in the system. So if you're a licensed professional counselor, you cannot bill in the system currently. If you're a licensed clinical social worker, you can. But we have a number of folks in our system who just their credentials, they have a lot of experience, but there are some systemic issues with like Medicare and billing. So I think that one is expanding system-wise who can participate in the system in terms of billing. The other piece is around just straight up a better incentivizing primary care physicians or budding primary care physicians. At this point, they work very, very hard, have a lot to cover in a short amount of time, are overworked, underpaid, and in some cases underappreciated. So the question is, how do we effectively expand who can participate in primary care, how primary care is rendered, whether it's through more telemedicine or telehealth, whether it is through expanding the team to include, to basically expand the role of naturopathic providers, to expand our training opportunities that we have, to expand the residency classes and the capacity that we have to train folks. I think that there are a number of arenas and areas, but it definitely is an issue. But I think that those are some of the places to start.
Thanks. Any comments on primary care?
Think big. For one thing, I'm delighted the question is about moving upstream to the young people. They deserve they deserve encouragement and a context in which they really can experience the joy of being a doctor or a nurse. And I'll tell you this about the youth. I think they're there ahead of us. I think that the universities that reach out and begin to help prepare people for the future we're talking about will find the young people already there. if we're really serious about it. The think big piece to me has to role definition. Maybe Alisha wants to comment on this. We need to stop thinking just about primary care doctors. It won't work. The expanded roles and the new scopes of practice have tremendous potential. It's time for the guilds to just get over it and embrace multi-professionalism. And if I can make one other comment, so I just lost a fight in Massachusetts as a citizen there that I'd like Oregon to start and win. In Alaska, there has been since 2003, I believe, the Dental Health Aid Therapist Program. In my state, Massachusetts, there are 290,000 kids on Medicaid who haven't seen a dentist in a year. Only 30% of the dentists have seen a single Medicaid patient. We have left dentistry with the mouth out of the guarantee, and that's not smart. In Alaska, there's access because they're taking junior college graduates, young people, training them in a very disciplined program that has been studied extensively by numerous researchers. It outperforms dentistry in meeting the needs of for simple restorations, filling caries, dental prophylaxis. So a kid in Scammon Bay, Alaska now can be seen by a DHAT, dental health aid therapist, that flies in and does complete dental care. I tried with others to get that passed in Massachusetts. It just went down last week, or 2 weeks ago in the legislature, opposed by the Dental Association. Wisconsin has it, Vermont has it, Maine's starting it, Alaska has it. I'd like to add Oregon to that list. And I think...
Thanks. John, any comments on primary care?
Well, I agree with exactly what's been said. I would carry it a step further beyond nurse practitioners, PAs, other alternative care providers. Very, very important. We actually have a quite large primary care workforce in Oregon. A chiropractic within their scope of practice are primary care providers, and we should take advantage of what we already have. But I also think we need to be thinking in terms of community health workers, because if you have the famous urban legend air conditioner story that you're all familiar with. If you have somebody checking on a regular basis to make sure somebody with congestive heart failure is not getting worse, the amount it costs to pay that individual versus an acute care hospitalization to stabilize CHF is not even in the same realm of comparison. So we have to pay these people what they're worth, and they actually reduce costs in the healthcare system, and they're a really important component, not just of the healthcare aspect, but also of the social determinant aspect of community health as well. So I'll take a real quick cut at this, and I see Don is ready to launch here.
I can't say that any better than he did, but basically, are choice and competition working to improve our healthcare system, or are they misdirected, and do we need to think differently?
So, I think that, first of all, I think we're competing for the wrong things. So if you look in the Portland market today, we have almost 60 urgent care clinics. These are dollars that are being invested in urgent care clinics. No one can tell me that that's reducing costs or improving community health. It's steering people to various hospital systems, and it's about competing for market share. So that's the wrong thing to compete on. Competing on cost and quality would be a different matter. And I also think you're absolutely right. As more people get insurance coverage, we have narrower and narrower panels, so people actually have restricted choice. And again, I don't think that has anything to do with quality of care. I think, again, it has to do with profit margin.
Other comments on choice and competition?
Go ahead. Yeah, I feel like I'm repeating myself here, but I think that with any choice, there are going to be limitations. And I think that right now what we have is a market, and where we want to move to is a healthcare system.
Last word, Dr. Berwick.
Last word. Well, that's a heavy burden. Divide the question. Let's talk about choice among insurers. Does that add value? No. I mean, it adds complexity. And we're paying a lot for that. And so that's what has moved me towards simplification of the payment side as a really great way to save some money without hurting anybody. So no, competition hasn't helped. I'm a member. I was the first administrator to become a Medicare member while I was there. And I remember going to sign up and looking at all my choices, and I just blurred. I mean, I don't know. I think so the simplification on the payment side, I'm for. On the delivery side, perhaps a little more controversy. Competition at the high end among our quaternary centers and cancer care and advanced radiotherapy, no. I mean, much more. We need to think about centers of excellence and some form of planning for how to meet the needs for pediatric cardiac surgery and advanced cancer therapy, and do it as a society that wants to be careful to make sure really good people are doing it and hold them accountable for that. More a utility model than a choice model. The primary care end, no, I don't think competition helps. Every doctors are trying their hardest to do it, and making doctor number one compete with doctor number two isn't the way they want to think. In the middle, for specialty and technical services, I might make a case, but I think overall, the experience goes the other way. Overall, I will claim the evidence is that in healthcare, supply drives demand. So the more you have of something, the more it's used. That is the way it works. And competition creates more supply. And even in my own university, I remember the day when the single radiotherapy system for all the Harvard teaching hospitals split in two, because there had to be competition between the two new big systems, and what we got was waste. So I'm not a fan of competition as a tool for achieving the future we want.
Okay, on that note, it's time to end. I want to wrap things up and turn the mic back over to Mike Marshall.
Great. Well, thank you. Let's give a nice round of applause for our panel.